Okay, hello everyone. Welcome to the Global Interdisciplinary Summit. I'm here today as a host. I'm going to moderate the session of Dr. Rita Singh, and I would like to present her because most of you know her, but I will read some credentials from this Nepalese diva. So, Dr. Rita Singh graduated as a dentist in 1987 in Bangalore, India. She completed her postgraduate degree in periodontics from Rajiv Gandhi University of Health and Science in India in 2001. She's currently the Vice President of Nepalese Society of Implant Dentistry. She served as President of Nepalese Society of Periodontology and Oral Implantology from 2017 to 2019, and I had the pleasure to collaborate with her there, and I was very well received. She had worked in the Department of Periodontology, Kathmandu University, as an associate professor till 2018. She's an active member of Divas in Dentistry movement worldwide. She has focused her topics of clinical work and research on implant aesthetics and soft tissue management, and had been lecturing internationally on these topics. Her 18 years of clinical practice in Kathmandu is limited to perio and implants, and she's also a member of Zonta International, that is an association that empowers women through service and advocacy in Nepal. So welcome Dr. Rita Singh, not only because she's a great clinician, but also because she's a great person with a big heart. So I will give you the word and I will return in the end to make the questions. Please post your questions in the comments. And we will select the questions. If there are not too many, we will do all. If there are too many, we'll select some questions. During 15 minutes after presentation of Dr. Rita Singh, we will do the questions and be interactive with the public. So good luck, Rita.
Thank you. Namaste. Thank you, Raquel, for the kind words. You know, to the whole world, you are that diva who manipulates that inferior alveolar nerve, but I'm lucky to know that compassionate and caring part of you. So friends, thank you so much for joining in. Anshul, are we ready to go ahead?
Yeah.
Yes, we are ready? Fine. So thank you, friends, for joining in again. And it's a pleasure to be here interacting with so many of you. First and foremost, I would like to thank this GIS, the group, the platform, where you have created such a wonderful platform for so many clinicians all around the world to share the knowledge and experience. And I'm really pleased to be a part of this movement, wherein I see a lot of brilliant researchers, skilled clinicians, and wonderful teachers. Thank you. As Raquel mentioned, I'm from Nepal, a tiny country which is known for the mountains, the landscapes, the cultural rich heritage, which is centuries rich. But if you ask people what makes them come back, what makes them come back to Nepal, they will say it's not just these attractions, but it's the people, friendly people with warm hearts, genuine hearts, and magical smiles. You have to believe me when I tell you that in Nepal, we do not use phrases like I love you or thank you. It's through our smiles that we communicate, and it's very valuable. Anshul, I cannot see myself. Is that fine?
Perfect, perfect.
Okay. But amidst all this, let me introduce you to a young man who has completely lost his smile. This young man, he hails from a remote village of Nepal. And as a migrant worker, he was in Japan for 2 years. Now, whatever money he earned in Japan for 2 years, he poured in, to get his smile back. He wanted to smile again because he had lost his central and lateral incisors. But unfortunately, a dark triangle started developing. And what happened over the years, that triangle became bigger, uglier, and darker. Now he had to come back because his mother expired and he couldn't go back where he was due for a soft tissue surgery. So when he came here for the first time and I saw his grimace on his face, I felt, okay, I'm not going to touch this patient. But today, when I really think back, I feel it was all justified, that anger, that disappointment, that disheartening, because he had spent all his hard-earned money all the time to get his smile back. And what he lost was, his peace of mind. He's so traumatized by this. I mean, you have to believe me when I tell you this. So why I'm sharing this story with you today is my topic is Peri-Implantitis. It's a disease which is coming as a public health issue. Now, it's very prevalent, much more prevalent than what it should be. And because of that, our patients are unnecessarily put under unjustifiable risk. I would say they will, lose not just the implant, but also the biological tissues. There is a financial loss associated with it and the psychological trauma. So with all these, it is gaining a lot of attention because if you see in the world currently, according to the reports, there are about 100 million cases of dental implants which are affected by peri-implantitis. And it is a silent epidemic. It's a topic of academic controversy and clinical challenge. There are a lot of controversies, and through my presentation today, I would like to demystify just a few of them because there are still controversies and we still don't know a lot of things there. So let me go into my presentation, and I have divided my presentation into 3 parts. First, I'm going to talk about the peri-implants disease, then I'll talk about how to prevent it, then I will talk about the treatments and a few of my cases. So let's talk about the peri-implant diseases. Humans, we fear the unknown. When there is a circumstance and we cannot acknowledge it or we cannot understand it, we are stressed. It really stresses us out, like how it has stressed during the COVID, during the present time. So whenever there is a new circumstance, what do? We try to take this new circumstance and try to fit in the pre-existing world. Now in the 80s, peri-implantitis just began appearing, what was done was the pre-existing condition at that time was periodontitis. So it was named also similar to periodontitis, and it was thought that these two diseases had similarities and the power of association. Even though it was not rational, they were considered like first cousins. So are we right to be considering these two diseases similar? Are the etiological factors are similar? So let's explore more on this disease. The prevalence. Now, the definition of peri-implantitis has been changed almost 8 to 10 times. And that is why we still do not know the true magnitude of the disease. We don't know. Some studies say that it's probably just like 1 out of 5 patients. And there's some studies which say 1 out of 10 implants that get affected. So we don't know. And the reason we don't know is because there is varying threshold for the bone loss, and also the reference time point from which the bone loss has occurred. So because of all these varying things, because we do not have the standardized approach, we still don't know how prevalent it is. Now in 2017, World Workshop sorry, let me go back. Yes. So in 2017, the World Workshop on Disease Classification, they gave us the latest classification of peri-implant diseases. And we know that there is a continuum from peri-implant health to mucositis and peri-implantitis. So peri-implant mucositis is the precursor for peri-implantitis. Now, in peri-implant mucositis, there is bleeding and suppuration on gentle probing with or without the increase in the probing depth. Now, the bone loss here is not present. When you compare with the crustal bone changes that has occurred after the initial remodeling, there are no bone changes. Whereas in peri-implantitis, the hallmark is bone loss, which is beyond the crustal bone loss, which is occurred after the initial remodeling. And of course, the bleeding, the suppuration, all the clinical signs of inflammation are there, and the probing depth is also increased compared to the previous examinations. Now, when we see a case of peri-implantitis, what do? We play a blame game. If we are not the ones to place the implants, probably we will blame the inexperience, incompetence, ignorance of that colleague. Or if we are the ones, we will probably be blaming the implant company, the manufacturers for the designs, for the connection surface, and maybe the patient for night grinding, for smoking, and so many other reasons. So at times we have to really see what is the factor which contributes to this disease, to this epidemic disease, which is becoming so prevalent. Now, the increased occlusal load, we know that whenever there is increased occlusal load, there is marginal bone loss. Now, when we have the unfavorable contours or the cements which are residual or we've left in the sulcus, they kind of attract the biofilm, and that again leads to peri-implantitis or the diseases. The implant malpositions, or when we traumatize the bone beyond the adaptive capacity of the pristine bone, there is necrosis and there is bone loss. Again, when we have the processes not seating well, they can act as niches, and the bacteria, the biofilm, can come in and do the destruction. Now, this is a case which was referred to me, and this patient had, I think, 21 implants. He had this discomfort and chronic pain, swelling. When I was trying to inject, you can see the pus in the lower picture there. The pus was exuding out. It was really in a very sorry state. Now, don't you think this kind of situation happens when we dentists, we are seduced by implants? We get addicted to it. Now, if you see in this case, whatever factors, etiological factors that I listed out in the previous slide, the unfavorable contours, the occlusal overload, the design of the process, everything is present. Now, where to begin, this kind of a treatment from? Now, luckily, this patient is not from Kathmandu, and I just did one sitting and he went back. Now, he was not in a state to remove the implants because he has again invested so much of time and so much of money. So just to show that, these kind of patients, they are put through unjustifiable and unnecessary risk just because the doctor or the dentist treating has not planned the case well. So what are we looking at? The bacterial infection. Liz Cotton has already told us that the microflora around peri-implantitis or the implants are same as those around the periodontal lesions. So the peripathogens, the periodontists are quite familiar with. But we have to understand, are these bacteria the causative organisms, or they are just casually present there? Are they really causing the problem? Because if they are causing the problem, intervening would make sense. But if they are just casually present there as secondary invaders, even by removing the bacterial infection, we are not going to have the resolution of the disease. So it's very important for us to understand. And this study from Canelo, he's shown so beautifully that only 12% of the cases that we see, like periodontitis, like peri-implantitis cases, they are plaque-induced. Rest 88% of the cases, they are either surgically induced, they are biomechanically or prosthetically or composite of all these, macro triggers. So what happens is, because of the suboptimal treatment, by us, that leads to the anatomic considerations, which leads to the secondary infection, and the patient suffers. And these could be in various forms, like the failure of the surgery, the guided bone regeneration, the malpositioning of the implant, cement residues, occlusal overload, and things like that. So these are all, it would not be wrong to say that we are the risk factors, the dentist. Now, the other alternative theory which Albrechtsen has introduced is something very interesting, because what he says is osseointegration is nothing but a foreign body equilibrium, and bone is basically formed to shield the foreign object. So whenever there's a disbalance in this equilibrium, the osseointegration is lost. And because of that, the onset of the marginal bone loss around the dental implants start happening, and the bacteria, they slowly start only as a complication, or they kind of invade much later into the picture after the bone loss has already happened. So seeing marginal bone loss as a periodontitis-like disease, according to Albrechtsen, is to be on the wrong track. And maybe he's right, because we see emerging articles nowadays which says that the metallic pollutants or the metallic ions which are present on the implants, there is 100% association between these and the granulation tissue. So when the granulation tissue is formed, obviously there is infection, and that leads to peri-implantitis. So it's time that we also try to see what kind of implants we are placing in our patients. It's very, very important, because it's not just good to believe that the implants are clean. We have to know for sure that the implants that we are using for our patients are clean. It's not enough just to believe or just to guess that they are clean. So this Clean Implant Project, it's come up with this standardization wherein they check all the implants, and I would urge all of you friends to go and see the implants that you are using have been through this project and what results they have given. So in today's scenario, I think rather than using peri-implantitis, other terms like crestal bone loss, osseoseparation, osteosufficiency, I think these terms, they kind of describe the scenario that we see in our patients. For example, this implant which I removed from my patient, there was no clinical inflammation. So when we say peri-implantitis, we always incline towards inflammation. There was absolutely no clinical signs of inflammation and impeccable oral hygiene. So I'm more comfortable probably to use a term like osseoseparation, wherein there is a disintegration in the interface between the implant and the bone, and crestal bone loss, marginal bone loss. That could just be an immunological reaction, to the metal ions. So we don't know. And osteosufficiency, again, this is something very nice to know, that it's basically a net contribution from the clinician, the patient, and the implant. So all these three components, ingredients come together, which are sufficient to promote and perpetuate osseointegration. So anything which is, any of the ingredient which is less, for example, the clinician's skill or knowledge is less, so the ingredients are less, so that leads to the state of non-attainment of the osseointegration. So this is something which is throwing light about the holistic approach on the peri-implant diseases. So bacteria, are they just a side phenomenon, or they are resorbing the bone? Because we have seen histologically that in the bone there are a lot of multinucleated giant cells, macrophages, which are actively resorbing. So maybe it's more towards the immunological reaction. Primary failure, is it because of the rejection of the foreign body from the patient? Is it an immunological reaction to the metal particles? We still don't have answers to these questions. And that is why I think whenever we are trying to relate the periodontitis with peri-implantitis, they look alike. They kind of have the same manifestations clinically, but they may actually, the etiopathogenesis may be completely different. Today we have scientific updates, so we should not be depending on the kind of assertions that were made long back in the 80s, most of them on the guesswork. For example, the ligature-induced models. Now, ligature-induced models, they are not the real models, and then peri-implantitis does not occur like that. So it's something like one car company saying that, oh, my car engine is so much better than yours, but when the oil is not inside the engine, it's something like that. It's not realistic. So we have to make sure that we have a different perspective when we treat these different diseases, and we cannot consider both of them as the first cousins and have the same treatment modalities. So let's try to think a little different when it comes to peri-implantitis. Now I would like to go to the second part, and wherein we talk about prevention. Why prevention? Because we know that there are no safe and sound protocols for peri-implantitis. We do not know what techniques work. We do not know what kind of chemicals, they are more effective. We have no idea. So it's better we stick to prevention. Now, EFP has given this guideline and the clinical recommendations. I'm going to go through one by one. The first one, inform the patient potential risk. How many of us really tell our patients about the complication, the possible biological or the biomechanical complications? When we go for a flight, the air hostess so beautifully explains us, describes how to take the oxygen mask and wear the life jacket. They tell us about the possible complications, right? So I think we have to also inform our patients about the potential risk. Never promise the patients that implants are forever, because they do ask us, are implants forever? How long is a guarantee for? I mean, this is something we keep hearing from our patients. And I think the best answer would be only diamonds are forever. I hope they are forever too. And also the foundation, in the patient and the doctor communication. I mean, it's so important. And especially before we start our treatment, that is the right time to set that stage. And using positively oriented semantics like revision surgery, instead of saying, oh, there's a failure, even if it is not your implant case, do not use these terms like complications, failures, because they don't sound reassuring to the patients. We have to be like the orthopedic friends who say, oh, we are going to exchange the implant or add the implant, remove the implant, and we're going to do the revision surgery. So when we use such terms like revision surgeries, I think we are better informing our patients, and they are also reassured. The population is much more secured listening to such terms. And it's better for the dentist, of course. Second is the risk factor. Analyzing the risk factor is very important. The local risk factors, the systemic risk factors. If there are any modifiable risk factors, for example, smoking, untreated periodontal diseases, we have to make sure that we remove. So when we say risk factor, it's basically the environmental, biological, or the behavioral factors which increase the probability of acquiring the disease. So we have to really know what are the risk factors. And of course, one of the biggest risk factors are us, the clinicians, the surgeons. So sometimes I feel peri-implantitis is the synonym for malpractitis. We may actually be doing so many things. We may have deficit in ourselves. For example, the knowledge, skill, and we may not be aware of it at all. And that is where I think, social media has played such a big role, because when we post our cases there and we get that crisp evaluation all around the world, it's so good, because sometimes what you're thinking, what the other person is thinking, you may not have thought about it at all. So, it's very good to kind of have a good team where the other person is also looking after the case, and you have a good team approach, integrated approach, so our patients are safe and we are safe too. And this is one of the studies which I just wanted to show here, where it was done in University of Toronto, Canada, where one surgeon always had more bone loss around the implants. So we just have to make sure that we are not that person, who is, inadvertently doing destruction or causing harm to the patient. This is my own case, very old case, where I placed the implant. And I'm not at all proud to say that, yes, I was a risk factor. At that time, we did not have the screw-retained facilities. So we had to go for the cement-retained and do deep placement. So this led to the fistula, which was seen in the patient. And this had to be changed later to the screw-retained prosthesis. And we know from the work of Wilson that most of the times, 81% of the times, the cement residues in the sulcus, they are associated with peri-implant mucositis and peri-implantitis. And whenever they are removed, 71% of the time, 74% of the times, they do disappear. So we have to make sure that we do everything right to make sure the cement is not left there, which is going to act like a nidus. Now, this is a very regular scenario which we get: insufficient ridge width. Most of the times we have patients, with this kind of bone, but we have to also think biologically. The bone, the cortical bone, which is there, is getting all the blood supply from the cancellous bone. Now, once we place the implant, what has happened? That the cancellous bone is no more there, so there's no vascular supply to the cortical bone, and thus it will undergo necrosis. So with this, we will have the bone level shifted. So we have to think about it and prevent it by either doing a bone grafting, or at least like we have to be prepared before we place the implant, sometimes before the surgery or along with the implant, we can do that. So these kind of risk factors, local risk factors, also will always, if we try to prevent it, we will not have patients like my first case who's not smiling. I mean, these are the small mistakes that we do, and the aftermath is so huge. Yes. And it's the soft tissue again. I always say that, of course, we have to place the implant in the prosthetically guided position, but periodontally guided position is also very important. It's not the bone which will determine your implant level. It's a soft tissue which will tell you where you have to place your implant, because you want at least 3 millimeter of the soft tissue thickness there to reduce the bone loss. So the odd ratio of the peri-implantitis cases, the association between the exposure and the outcome, we know that poor oral hygiene, tobacco smoking, history of treated periodontitis, residual pockets more than 5 millimeter, all these, whenever they are present, they will increase the probability of peri-implantitis. Now, the prosthodontic design is another very ignored part, I feel, because so many times we place the implant and we just give the prosthetics that have been supplied by the lab, by their own design, and we don't really contribute to the design. So that is really wrong. In this patient, she had her centrals restored with the implants, and she had this inflammation, swelling for a long time, and she was referred to me for periodontal therapy. But actually it was not because, if you see, her rest of the gingiva looks good. It was the crown which was the culprit. So most of the times, we like to flaunt our full mouth cases, but I feel that the crux or the success of our full mouth cases lies in the intaglio surface. If we have this bandage of bacteria under the prosthesis, we cannot call these kind of cases, because it is going to lead to biological complication. Now, this is another case where I did the immediate implant, did the sinus lift, and spent a lot of time customizing the healing collar at the surgery. So I got a very beautiful cuff. But what happened later? The lab, they made the definitive crown, and of course I used, if you see, I have used the most expensive and the latest material. But just because the design was wrong, there was so much of food lodgement, and I just had to repeat the whole thing. So prosthetic design is also very important for our longevity of the cases. Steam cleaning. We know that the junctional epithelium and the connective tissue, they only like titanium, or they like the PEEK or zirconia. But it's not just the materials which are polished, they also need to be very clean. So steam cleaning, which I always emphasize, is such a small thing but very crucial for the success of our cases. Now, quality of soft tissue is something that I can really speak volumes on, but we have to understand that whenever, it's a very controversial topic again, but whenever we have the keratinized tissue 2 millimeter on buccal and lingual, we are safe, there is less plaque, there is less inflammation, patients don't have discomfort and pain, they can brush better, and we have less problems. And the study shows that whenever there is lack of attached gingiva, attached tissue, and we also combine with the regenerative procedures, there are higher chances of peri-implantitis, and that's what we have to know. Sorry, I pressed something. I hope this is fine. Okay, so I just wanted to hide the icon and I think it's worked. Yes. So we have to always make sure that we have adequate attached gingiva around the cases. And of course, we can always take the soft tissue grafts and apically reposition, do the different soft tissue techniques to make sure that we have that connective tissue, the attached gingiva. Now, the soft tissue graft from the palate to the tuberosity, they have the blueprint. These tissues, they have the blueprint for the keratinization. So whenever required, whether it's before the implant placement, during the implant placement, at the second surgery, or sometimes even post-surgeries, post-cases, we should do it. Now, plaque control is another very, very important part, which I think most of the clinicians take it for granted. Now, patients, they really need to know how to take care of their implants. They have their self-performed oral hygiene measures should be of high standard, and they should have good knowledge about what to use and what is good. I don't think floss is a very good cleaning tool to use around the implants. It's interdental brushes, the water picks, these kind of oral irrigators, which are so much better to remove the biofilm. So high standards of daily patient-delivered oral hygiene, no matter how many times we call our patients to the clinic, but if they are not doing the home care, the oral hygiene every day, it is not going to make sense. So it's very, very important to sit with our patients, spend some time and tell our patients how to use it. We have to demonstrate in the mouth. And this is everything about behavioral modification, which is not just about educating. You have to spend that good amount of time with your patient and also instruct them, see what they're doing, and recall them, and again analyze or evaluate them. This is the only mantra for success in peri-implant cases, I feel, because if patients are not cleaning well, it's not going to last long. So the recall and the remotivate, we know that whenever we call our patients, we have to remotivate, we have to reinforce the oral hygiene. Now, the picture that I have put here is just to show you the difference when the patient, she has gotten a dental implant on the upper left central incisor. So when she came after a year, what I realized that she had not brushed well and there was a lot of plaque, but only around the implant there was an exaggerated response. And we know that the capacity, the sealing capacity of this area is much weaker than the natural teeth. So it's very, very important that we tell our patients, what happens when they don't clean well. We have to relay this information to them also. And whenever the changes over time period, we see that kind of a thing, we have to know that it can be an alarming sign. So in the recall visits, it's very important that we do our part. It's not just about cleaning and maintenance, but also reinforcing the patients. And enough literature there which says that patients, when they do not adhere to the supportive periodontal therapy, there are chances of implant loss, peri-implantitis. And this retrospective 5-year study done by Costa et al., it shows that in 5 years, there were only 18% of the patients who were complying to the supportive implant therapy, and they got peri-implantitis. But the corresponding proportion which did not adhere to the supportive periodontal therapy or the implant therapy was 43.9%. There's a huge difference. So it's very important that we recall our patients and we make sure that they know the advantage. So when we talk about prevention, we have these 3 layers. The first is we have to do it even before we start the implant placement. Make sure that patients know how to brush. They have stopped smoking. They know the value of it. They are motivated. They are psychologically prepared for dental implants. Then the second is when they have the implant, we have to make sure that their adherence to the regular supportive implant therapy is there so that we prevent the diseases. And the third is what we're going to talk in the next session, where the therapy of the peri-implant mucositis, once we see that there is mucositis, we should not tiptoe around it, but treat it so that it does not get converted into peri-implantitis. So the third part is about treatment and few of the cases that I had to manage with the peri-implant diseases. Now, let me tell you that in Nepal, we have 330 million gods, more number of gods than people. We have gods for good grades, we have gods for marriage, we have gods for diseases, I mean, name it. And we have God even for toothache. And this is my selfie with the god of toothache. This is a very old temple in the heart of the city where people go and stomp the coin so that they don't have to go to the dentist. This century-old practice, and still people do that. Why I put this picture here is I feel because we do not have any treatment strategies, the safe and sound treatment modalities for peri-implantitis, we have to send our patients to the temples to pray because we don't know what is going to work. We don't know the fate of that implant which is infected. So let's see what can we do once we have the disease. Now, the only sure protocol, this is the same patient that I introduced you in the beginning. So he had one implant which was malpositioned and I removed it. So the only predictable treatment for peri-implantitis is actually removing that implant. But of course, after that, also you have the soft tissue and hard tissue, which needs to be restored back, right? So when we have peri-implantitis cases, we have to first decide, are we going to keep the implant or are we going to remove the implant? Now, if you're planning to keep the implant, we have to first start with the non-surgical therapy. And the non-surgical therapy, how long do we wait for? We wait for 1 to 2 months. And if the case is not responding well, then we subject the patient to the access surgery. Now, when we do the access surgery, depending on the defect morphology, we can either do the resective or the regenerative approach. Though nothing is 100%, there are no data which shows that these are successful on a long term. But these are the things that we do. And after the surgery, again, we have to place our patient in evaluation and see. So if the infection is resolved, we continue with the supportive implant therapy. And if it is not, then we might as well remove the implant. So this is how we take a case of peri-implantitis. Now, non-surgical therapy, there are so many things we can do here: mechanical debridement, the antiseptics, ultrasonics, antibiotics, laser, photodynamic therapy. It's quite exhaustive, the list out there. I mean, there's even for the antiseptics, there's a whole array of these chemicals that we can use over the implant, and no comparative studies as such has shown that one is better than the other. So the 3Ds that we have to remember: disrupt the biofilm, number one. Then detoxify the implant surface or the implant abutment connection. Connection disinfection is also very important. So we have to detoxify our implant surfaces. And then we go to diluting the bacterial load so that it promotes healing. It allows for the healing. So the foundation is always, the mechanical debridement. We have to make sure that the biofilm is disrupted. And this reminds always me of the fish tank. When we have that slimy layer on our fish tank, we cannot just put some antiseptics and antibiotics. We have to scrub it. So this is exactly what we have to do around our implants. But of course, the instruments have to be right. Now, there's so many different kinds of instruments in the market. At one point of time, I remember I was told that the plastic curates were good. But when I did, when I used those, I just didn't know what I was doing. And then later somewhere I read that plastic curates are of no use. And they're probably just good for gardening. So we have to really make sure that we are also equipped right. If we are doing implants, we have to have these instruments because our patients are going to come back with some kind of biological problem. So the titanium curates which are there, or the rubber tip on the ultrasonics, they are the best ways to do the mechanical debridement. Now there's a whole lot of area again about decontamination and detoxing. Locally applied chemicals, then the hand instruments, all these things are also used to decontaminate. Now the funny part out here is a laser, which is probably $5,000 worth $5,000, is as effective as a cotton pellet which is soaked in hexidin. Isn't that fantastic? So we really have to see what kind of chemicals, what kind of instruments are we using, because just for peri-implantitis, we are not going to buy the expensive laser. Diode is of no use because it generates heat. So we have to be really versed with the kind of therapies that are available there. And photodynamic therapy is gaining a lot of attention in the recent past, and I have been using this a lot because it's very easy to use and it doesn't take time. So whenever I'm doing my immediate cases or any cases where I suspect any kind of infection, I do this, because it's just like maybe 5 minutes it takes. So this is basically it uses a low diode, the low laser therapy in conjunction with the photosensitizer, which binds with the target cells, and the reactive singlet oxygen, which are bactericidal, which are toxic, they're released and they kill the bacteria. So this is of a lot of use when it comes to peri-implantitis. But the only problem is we do not have long-term studies, and I hope in future we will get long-term studies as well. So when we treating the peri-implant mucositis, here we are it's something like gingivitis, but again, we should not be fooled, because gingivitis, we know it's reversible completely when you have good oral hygiene and you do the debridement. But not all mucositis, they are reversible. Not all they resolve. And probably that is why we have to think that there is some missing link. There is something that we have not really understood until now. So when we get cases of mucositis, the protocol that we have now is, first, the patient has to have good oral hygiene. The patient self-performed plug control should be good. And we do the mechanical debridement with or without the use of the antiseptics or the antibiotics. Now, once we do this, most of the cases do resolve. Now, the Peri-Implantitis Protocol, which is given in 2018, why I highlighted this particular point is sometimes when we are treating peri-implantitis cases, we don't know how long to wait after the non-surgical therapy. In periodontal therapy, we are told to wait even 6 months, 1 year sometimes, that you should not jump into the surgical phase right away. It's not good. But when we are treating peri-implantitis cases, we cannot wait so long. It's not good to be tiptoeing around the problem. So we have to just see whether it's responding to the non-surgical therapy. If it does not, then we go into the surgical therapy where we access the flap, and then depending upon the defects, like I mentioned earlier, we have to remove the granulation tissue and do the regenerative or the resective therapy. And of course, all these cases will have to be monitored in the supportive therapy, because just because we do the surgeries does not mean that these lesions are going to resolve. And it's very important that this point, we put it across our patient. Our patient, they need to be with us during each step of the treatment. You do all the surgeries, you put all the expensive bone grafts, membranes, everything, and after 1 year, you cannot tell the patient that you're going to remove the implant. He's going to get a heart attack. So please make sure that you communicate with your patient everything, and sometimes if a patient is not willing, it's better you don't go ahead with the treatment. So the surgical therapy, when we come to the surgical therapy, we have to again raise the full thickness flap, do the resective or the regenerative, and explantation. This is again always the part where we have to work. Now, peri-implantitis, this is just to give you an idea about the early, moderate, and severe, depending upon the probing depth. Just like about 5 to 7 millimeter in the early group. The moderate group, we have about 6 to 10. And if it's severe, there's no treatment. We just explant. Now, when we have the early, we don't really try to do the regenerative procedures and just do the resective. But when we go when we have the moderate kind of cases, yes, these are the cases where you can try the regenerative modality, but then we don't know the bone that we put, is it going to be restored? Is it going to be sustained? We don't even know. Is it going to osseointegrate? These questions nobody can answer. Something which I came across, and I felt there is a light at the end of the tunnel, the Galvanoelectric Approach. This is basically you the implant serves as a cathode, and the liquid, which is charged by the anode, and the hydrogen bubbles which are produced, they kind of decontaminate, or they dislodge all the biofilm. And there are animal studies, there are in vitro studies, and now they're coming with a lot of studies which I'm following, and it's very interesting that almost 50% of the cases, they have seen re-osseointegration. So who knows, maybe we do have some solution to our problem in the coming days. So let me take you through some of the cases that I have done. These are just the normal cases where I did see some kind of problem around the implants, and I had to do something, to save the implants. So this is my patient whom I did immediate implant in 2014, and a decent prosthesis which has been given, and every 6 months religiously this patient comes to meet me. So things were going quite fine. But in 2016, I was traveling and his crown fell off. So when he came to the clinic, one of my junior dentists did the cementation, and she was new and she had no idea how to cement around the implant abutment. So she put a lot of cement. So the next time when he came, I could see that there was some amount of suppuration. The probing depth was fine, but there was some amount of suppuration, and I had to remove the cement particles from the sulcus, and then it is restored back. And why I'm showing this case here is whenever you see some kind of a disease, we have to make sure that we intervene right away. We should not wait, because if I had waited another 6 months, maybe this mucositis would have converted into peri-implantitis. So these are very simple things that we can do and save our patients. And this is the X-ray that I have been taking. This is just few of the X-rays. So every year we take it, and if you see, the bone level is almost the same. So whenever we are doing these kind of cases, we should not wait and watch, and we have to make sure that we are going and we are doing the treatment right away. I think somewhere in the middle, I missed a point of probing. What I wanted to say is probing is so important that we try to equip ourselves with the very expensive gadgets, like say the intraoral scanner, the Ostel device, everything. But it's the probe, the periodontal probe, which is going to save you from a lot of problems, because this is the only thing that will tell you the condition of the tissues. And the interesting part is the bleeding on probing. It's so controversial, actually. Bleeding on probing, a lot of, and there's a school of thought that you should not probe around the implants, or you should not use the metal implants, but that is wrong. You must probe at every visit. And that is the only way you get to know how the tissue is like. And obviously empirically, the plastic probes are better because they tend to flex, and they especially around the bulging contours of the crowns. But otherwise, we can use metal probes also, because when we use metal probes, and even if suppose we have gone through the junction epithelium, disrupted the connective tissue, we know by the work of Ettel et al. That within 5 days, it is restored back to health. So probing is so important, and I feel most of the times the dentist, when patients come for the recall visit, we just clean, do the debridement, but not probe. But that is one point which will save you from the problem. And it's so important. Bleeding and probing, it has got the negative predictive value. When I say negative predictive value, it means that if the bleeding is absent, then there are less chances that the problems are there. But just because it bleeds does not mean that there is peri-implantitis. Sometimes it could just be because of the disrupting of the junction epithelium. So you have to monitor these changes over a period of time, and it's so important to probe around our cases, which I feel we normally don't tend to do it. But that is the most effective tool and the technique to save us from a lot of problems. Okay, so let me take you to my next case, wherein the patient had already got the crowns from the previous dentist, and this inflammation was there, and it was just not going no matter what. So when I looked at it, I did debridement once or twice, but I could feel that the problem was not due to the biofilm. The problem was because of the iatrogenic crown which was present. So I removed the crown, and you can see the angulations were pretty bad, in the sense it was not optimal. So I decided to open this patient up and put the connective tissue there, just to increase the bulk or the volume of the tissues. And then we gave the crowns in a way which is conducive for the cleaning. So here you can see the difference between the prosthesis which was given before, and now how the tissues are nicely wrapped around the implants. So it's very important that whenever we see inflammation, it's not just the plug, it's not just the bacteria. So many times it's us, something, some kind of problem that we have not been aware of. So this is just to show that sometimes just the design can actually help us restore the tissue back to health. And she's so happy to have her teeth. It's so much better also, looks better also, and it's healthier. My next case that I'm going to show you is a case wherein the patient already had these 2 implants before coming to my practice. And I was working on her upper areas, but then I detected that there was some problem. So when I probed, I did see that there was some amount of suppuration. And this is what I meant. This is one instrument, the cheapest instrument that you require to diagnose and monitor your cases with peri-implantitis. I think periodontal probe, whatever you're comfortable with, plastic or metallic, is a must. So after the non-surgical therapy, I could see that there was not much of an improvement, and there was still suppuration, there was still bleeding. And after a month or so, I decided to go for the flap. And here you can see that I have first elevated a full thickness flap, and then I went partial. And I also harvested graft from the palate and placed on the site, because I knew I did not want to do any kind of regenerative technique here, because in the x-rays there's almost about 40-50% of bone loss, and I had frankly speaking, I didn't have the courage to do any kind of grafting here, because I knew that it would fail at some point of time. So I did the soft tissue grafting here, and you can see that the tissues healed pretty well, and at least there is no bleeding and pus. I don't know for how long. I mean, sometimes I feel when we do these kind of surgeries, we're just buying time, and we're just giving that time for the patient to be prepared psychologically, which is so important, of course. So this is how I treated this case, and every 3 months, religiously, she comes to me to show if there is any problem. But so far, it's been doing pretty well. Now, this is another case, very interesting case, where again I feel the dentist was probably seduced by the implants. There were so many implants, and you can see there's some implants actually failing. Now, this patient, she's 75 plus, but amazingly, she was so aesthetically concerned. She hated those metallic collars which were seen. And again, if you see here, there is no bone on the buccal side. Now, again, for this kind of a defect, I did not want to do a GBR, and especially because considering the age of the patient also. So I coronally displaced the flap, and I took the connective tissue from the palate, the Zucchelli technique, and you can see that I used this titanium brush. Now, I don't know if you ask me about titanium brush, they are good or bad. Studies have mixed results, but something to decontaminate before placing the graft. So this is how I placed, and waited for the healing, and very robust tissues, and she was very happy that the metallic collars were all hidden. So just kind of like, these cases, I'm not trying to see that, oh, I'm able to regenerate bone, and just my daily cases of how I dealt with these normal cases. So my last case is a very a case which is very dear to my heart, because I get palpitations every time I show this case. And I tell everyone that whenever this patient comes to my practice, my heartbeat is literally vibrating. And this is my first ever immediate implant. And here I was the culprit again. No, nothing. It was not the bone. It was not the implant. It was me, because I chose the wrong diameter. I could have gone for a smaller diameter. I placed the implant not knowing that that buccal bone, which was there during the implant placement, would go away, because that's a bundle bone. So I had no idea about the biology, about the understanding of the disease. And if you see the aesthetic risk assessment, this patient definitely is a high risk category patient. There is like multiple teeth missing. So how I went about this case is I reflected, and I planned to give him one more implant. So I placed one more implant in the central area. And for this implant, I did implantoplasty. Now, I know those who have done implantoplasty will say that it's not a good technique, because the kind of metal ions and titanium particles that come out, I don't know how to control that. I mean, this is something we should really not really consider a proper treatment. But the reason that I did here was I had to retain this implant for the sake of provisionalization for 3 to 4 months. So I did the implantoplasty just to make sure that I can place my soft tissue graft from the tuberosity. In fact, I also harvested from the palate and place in the area, so that when the tissue is healing, because soft tissue, they don't like rough surfaces, so the tissue heals much better. And I removed the implant after the second implant integrated, and this is how he is today. Now, if you this is already, I think, about 6 to 7 months ago. I haven't taken the pictures. I have not put in the presentation, but it looks so much better. And how he was in 2007 when I did it for all these years, and now there is a huge difference. And I'm telling you, the soft tissues are much better now. So what do I want to tell in a nutshell? In a nutshell, I would like to say that let's be biologic. Biologic because let's place implants only in the stable tissues. Let's place implants where there is good amount of keratinized tissue. If it needs bone grafting, maybe sometimes we need to delay the insertion of the implant. And the prosthetic designing must be such that it allows for the tissues to heal well and to be cleaned well by the patient every day. So these are small things that we have to remember, so that we do not increase the number of peri-implantitis in the world. It's already so high than it should be. Multifactorial etiology means that it's not just plaque induced. It's not like periodontitis where we know what is the causative organism behind. Here it's multifactorial. It's not just plaque induced. It could be prosthetically induced. It could be surgically induced. It could be biomechanically induced. And the biggest risk factors are us. So we have to find out what are the deficits that we have in our skill and our knowledge, and try and go take courses and learn, take help from others, so that we do not contribute to the already emerging public issue, the public health issue. And because we do not have the safe and the sound treatment, the best treatment is prevention. And if we prevent these cases, we are not going to have cases like this. Patients who are distressed, disappointed, disheartened, and you can't even blame them, because they have really poured so much of money, time, and that psychological trauma that they go through is just not right. And this is his picture right now. What I've done to him is I've given a provisional with a pink composite, which he hates. But what I'm trying to do is just bring down his expectation. I don't know whether I can give him his smile back, which he's been missing. I really don't know if I'm going to be able to do that. But at least psychologically, I'm really trying to help him get used to, the actual fact, and tell him that you cannot expect, your tissues, everything to be normal. Probably the previous dentist had not counseled him in that way, and that is why he wears that grimace, and you can see that half smile. Sometimes nowadays he gives me that half smile, and I just hope that one day I will be able to give him his smile back. So this is so related with the topic today, peri-implantitis, because there are known knowns, things that we know, and there are known unknowns, things that we know we don't know. But there are also things unknown unknowns, the ones which we just don't know, And I think for COVID also, it's just the same, because we just don't know what things are there. And as a dentist, my fear today is whether I'm going to go back to my work, that the lockdown is now getting over. Am I going to go to the pre-existing world, to my old way of practice, or I'm going to have to adapt to the new circumstance where you can see Delia, she's amazingly, she's been working and giving all the different protocols, for the dentist. So I don't know whether we have to really do this way, put rubber dam for every patient. So I just hope that we get back to normal very soon. I don't know if it's the new normal or the old normal, but with this, I would like to end my presentation. And do I... Raquel, are you there?
Hello. You can close your presentation.
Yes, did I close?
Perfect.
Yes.
Thank you so much for an amazing presentation, very informative. We have some questions from the audience, and if we have time, I can also put some questions, because it's a very interesting topic and a very important one, because we are practicing implantology for many years. Of course, we also have to deal with peri-implantitis and more. So we really need to address to this issue. So the first question from the public is from Dr. Cristina Torres from Portugal. And she asks, like, if you have less than 2 millimeters bone loss, do you recommend bone augmentation or reducing the platform of the implant?
If I have less than 2 millimeter of bone loss, I think I will not do anything. Right? Because, of course, if it's in the aesthetic zone, then the soft tissue grafting would help. But if it's a posterior zone, and if it's just for the bone, I don't think if there is 2 millimeter bone, I will make sure that whatever sulcus is there is healthy. There is no disease in that soft tissue around the implant. I would not regenerate bone at all.
Yeah, I agree, because 2 millimeter is a space that even when we have a gap, jump of 2 millimeters, normally we don't put biomaterial, because it's something that is not going to be regenerated, or is going to be regenerated automatically.
And we don't know the bone that we place, is it going to turn over? It's a $1 million question.
Yeah. If it will be autogenous bone is one thing. Being with a xenograft or with the other biomaterial that is synthetic, I don't think is a good idea.
And even autogenous, you just put the slurry, autogenous that we get out of the drills. I don't think that also helps. Either you really build like the Curie technique, but I don't think just placing some autogenous chips will also help, actually.
Okay. The second question, I can't see who did it, but I have access to the question, is asking, can a peri-implantitis turn into a neoplasy with time? If you
Yes,
have the,
I think there are few studies which have shown that in some cases of periimplantitis, there were, these kind of tumors. But of course, like we know that they're completely different entities. But it's just that I think not because of the.
yeah, but maybe they can potentiate.
You can answer that question better.
No, the question is for you. No, but of course, there's different things. So, because peri-implantitis is something that
Inflammatory
has
neoplasm. Yeah.
a different component, but maybe if we have like a predisposition to myelinization or even for
Yes.
a tumor, maybe if you have on top
Yeah.
peri-implantitis,
If
of
there is
course,
a swelling and we think it's because of the peri-implant infection, and we don't rule out the neoplasm,
yeah.
sometimes.
A cofactor also.
Yes.
A factor of developing is like having a peri-implantitis and you have a patient that is a diabetic. Of course, is a cofactor, a negative cofactor for the evolution of the disease. If you smoke, is also another cofactor. So I think we should consider as cofactor in the evolution of the peri-implantitis or the neoplasy. Another question is, this doctor has a case of immediate placement implant of lower 6, in which post 3 months there was crestal bone loss in the lingual side, exposing 2 threads of the implant. And he's asking, how can I manage that case? And can I trim off the exposed threads and give prosthetic accordingly?
I don't think it's a good idea to trim the implant, because how much do you trim? And even if you polish, like I showed with the greenies and the brownies, how much to polish? There is, no protocol. So I think when we have a case with peri-implantitis, we have to first know what is the cause. The lingual is usually, lost after the buccal. But if there is lingual, maybe to start with, the implant was not placed in the right platform, I would not really say touch the implant. I think it's best, regenerative vertically around implant, around teeth, we say it's so difficult. And your, yes, I would say just clean that area well, and take that patient into your confidence. You have to, tell the patient the right thing. And at times I've seen that patients, when you are honest with them, they really appreciate.
That's true. But do you think, for instance, soft tissue improvement around the implant could solve or help solving the situation?
The soft tissue, depends what phenotype. If it's very thin, yes, maybe. But lingually, I've never done any soft tissue grafting on the lingual side, so I'm skeptical. Maybe use some photodynamic therapy or some kind of antiseptic just to keep that, implant. Just buy some time, I would say.
Yeah, I agree. I also used antimicrobial photodynamic therapy, elbow blue, and I'm having very good results. I don't have any research study, but there are so many publications in the literature that supports this kind of therapy. And for me, really, it's working, because many times only association, of course, you have to clean first, you have to give some hygiene to the patients, you have to do the debridement first, you have sometimes to even do antibiotics first, and then when the pathology starts to get controlled, I think the elbow therapy, the anti-dynamic photodynamic therapy, is really a good help. Also, the air powder that we have in our office, at least my feeling is that it works very well. But what is proved now in the literature in the last months, that even rinsing with water or with some LEC,
Hydrogen peroxide.
sometimes even is not a big difference. So the water peak, the water is really important, the removal of the biofilm. So there's some publications, recent publications regarding that the water peak is the most important thing in maintaining the hygiene of the patient. Of course, if he doesn't do the maintenance at home, we are not doing miracles in the office, but it has to be teamwork between the patient and the doctor.
Sometimes when I do full mouth cases, I gift my patient in a water pig.
Yeah, me too.
It's for you.
Offer, because I know they will treat much better the treatment, and they will not so many times to the office with problems. We have the same philosophy in two parts of the world, completely different.
Yeah, true.
We have the same philosophy. Regarding the question, when you have a peri-implantitis and you have like a big loss of bone, imagine like half of the implant length. What is your this is my question, okay? What is your criteria to treat or explant? Do you have any guideline? It can be your guideline. I'm not asking what is in the literature, because it's as you told, peri-implantitis is something that there's no guidelines totally established, and some people are doing like this and some people are doing like that, and I have better results like this. But in your experience, if you have like half of the implant without bone, but for instance with good soft tissue, what will be your criteria to try to explant and start over, or try to regenerate in high? Of course, it depends on the walls, if you have peaks, whatever. But what will be your main criteria for the decision between explantation or regeneration?
If I have placed that implant, I will try to save it by any means. But jokes apart, I mean, when we have that kind of a case, we have to see the attitude of the patient, right? That is the first thing. So if the patient is okay to let the implant go, but of course 50% is borderline. And if it's a posterior and still functional, we probably just want to see for some time. I had a patient who had implant done 20 years back, and the implant was almost like 18 millimeters. And finally I took it out, but you have to give some time to the patients to get used to it. So when 50%, then that it's downhill. It's not going to get better until and unless the patient really has that immaculate oral hygiene, which is difficult.
It also depends on the progression.
Yes.
If it's progressive or if it's stable. Because if it's stable, sometimes we can...
sometimes, we will have
the hygiene, and we can maintain the controls like a little bit short time. Maybe we can have and sometimes even treating only with soft tissue to improve the sealing.
Like I showed in one of my cases. I mean, it does help. It's not that you always need bone covering your implants. It's better, but sometimes you can also protect with the soft tissues, I feel.
Yeah. Also, another, this is more a comment, but also like a debate with you. Do you think one objective measure to have the decision about doing regeneration or explantation can be the ISQ, the implantability quotient? Do you normally use this guideline to have the option? I don't know, if you have an ISQ lower than 50, for instance, you remove the implant, or if you have more, you try to regenerate. Just a question of sharing experience.
Yes, I mean, of course, if the implant is being considered for explantation, then ISQ, provided that you have the pegs. I have the ISQ, but sometimes some implants are there. Problem. If I have the peg, obviously, I want to, see the ISQ. It will help, because at least we'll know whether it's going to be difficult to remove also, because sometimes removing implants is disastrous.
Exactly.
Yeah, it's a nightmare.
Because many times you try to remove with the traditional implant removers and it breaks, and you have to go with the burr all around.
Yes.
So sometimes it's a mess. Yeah, I agree. So I was asking because I'm using also the ISQ when I think that it's really borderline to explant or not. I measure the ISQ, and if I have a very low ISQ level, namely I consider it lower than 55, I remove it. I prefer, and I build it again. If I have an ISQ of 70, even if I have only 1/3 of the implant, it means that the implant is quite stable, so I maintain the implant, because sometimes it's not about the amount of implant that is inside the bone. It has to be with the quality of the bone, and also the quantity of the bone around it. So that for me is a guideline that I normally use, and I think it's a good guideline because it's something that is objectively to use. Another thing, let me ask, do you normally use systemic antibiotic before going to the debridement, to the non-invasive treatment, periop treatment, or you first do the treatment and then eventually give the antibiotic? And if yes, what type of recommendation normally you use, or if you use only one antibiotic or some association, what is your protocol in your clinic, what you do normally, and if you have good results with it?
Antibiotics, well, I use it only if it is really a case where we need to, because I don't think systemic antibiotics can really help. Of course, if you're doing some major surgeries, we give it before the surgery, but for Peri-Implant Mucositis and Peri-Implantitis also, I don't really think. I would rather go for elbow, something local, wherein you know that you have disinfected the antibiotics rather than giving it systemically. I feel, because even if you see the papers, the research, there is no substantiated results about it. If I would give a combination of amoxicillin and metronidazole, the broad spectrum.
For aerobic and anaerobic, but you prefer to use the elbow glue because
I would go for something local rather than
a topic approach without systemic inconvenience. And I totally agree, because if someone saw my lecture at Global Implantology Summit, I talked a lot about elbow because I'm using for the last 5 years and the results are really amazing. And even sometimes to improve the healing and to avoid the inflammation, not only as a photodynamic therapy, because even if you use the red soft diode laser locally, you can have an anti-inflammatory
low level laser therapy.
Healing.
Yes.
Only the question, if you use the dye, the methyl-toluene blue, you will target the bacteria and you will kill the bacteria, as you explained, by oxyco-reduction reaction.
Yes,
so
reaction.
It bursts the bacteria. So I'm using in all my protocols of post-extractional or peri-implantitis.
Yes, even I do it for all my perio cases and implant cases, because it's easy. And when you have something, you want to utilize it, right? And which is scientific.
Follow up, exactly. Because Ashwini is also asking if you use in a normal basis elbow.
Oh, yes, I use it for every purpose, wherever I see infection, for immediate cases.
Do you also use it for not only for bacteria, but also for virus and fungus, like for herpes or candida? It works, at least for me, in the cases that I use. I don't have so many cases that I needed to use, but the results were really, really amazing.
Because it's non-discriminatory. I mean, it's for, every pathogen.
Exactly. It's not antibacterial. It's antibacterial, antiviral, and antifungal.
Fungal.
So another question is there any diagnostic test to predict foreign body response to implants?
Not to my knowledge.
I don't know if that was the purpose of the question. There are some tests to see the type of bacteria you have. This is you can do in teeth and implants. Also, there are some tests that you can do with the saliva to fear the, how can I say, the kind of I'm trying to explain in English, previsibility of having the periodontal or periimplantal disease. There are some genes
Okay.
that some people have
Yes,
this,
chair side.
but they are quite expensive. But
Expensive.
sometimes, at least in my office, in cases that I try everything and nothing works, I normally do this test of genetic profile.
Oh, you have access to it. That's nice.
You go, it's not so expensive, it's a little bit expensive, but normally when I don't solve the problem with the traditional approaches that I use, like you use the systemic, local debridement, elbow, irrigation, chlorhexidine, whatever, if I can't solve with this, then and the patient normally is a high risk patient with immunological problems, or I try this to do this, we call it like the genetic test to see if they have a specific tendency to have periodontal or peri-implant disease. And at least it's something that gives you an idea that you did all that you can, and sometimes the patient has this characteristic, so you can't change that.
That is the only thing that you cannot modify, the risk factor, genetic makeup.
Exactly.
So
That you can't modify. The only thing you can modify eventually is if you have a notion of the specific bacteria that you have in the sulcus, you can optimize the systemic antibiotics. But to be honest, almost all the time you use always the same antibiotics. So it's not so important to detect which kind of bacteria are producing the problem. So it's good for scientific research. It's good for someone that is trying to understand the physiopathology behind the implantology. But for a clinical purpose, I don't think it's such important. I only use it twice, to be honest, in 18 years. I also worked for 18 years, coincidentally. And the two patients had this predisposition to periodontal disease. So at least they knew that I was trying and I was doing everything that was in my range, to solve the problem. But sometimes we can't. We are not God. Medicine is not mathematics. Sometimes we can't solve the problem. So at least we know that there's a reason behind not to solve the problem.
Yes.
So let me see if there's. I think there's no more question. Done. I think it's enough. Thank you, Rita, for your amazing presentation, for your sharing your experience.
I just shared my little experience.
No, but it was
something
great.
Which I have, seen in my practice. Nothing glamorous. Nothing. Something daily.
I've been to your practice, and you have a very good practice. And for Nepal, is something very huge and very well equipped. And you have a very good team, I know. And I know that you are a very strong professional and very motivated one. And I wish you the maximum success. And you always can count on me.
Yes. Thank you so much for moderating the session. You really made me very comfortable.
Thank you. And hope to see you soon, presentially. So take care, stay safe.
You too. Okay. And thank you, friends, everyone, for being there. Thank you so much.
Bye-bye.
Bye-bye.